So I will discuss renal replacement therapy requiring acute kidney injury in children and neonates, talk about timing and some advanced machines and techniques. And of course, to do that all in 20 minutes means that I'll have to skim the surface. But one thing that I like to point out about acute kidney injury, it is probably the one nephrology where pediatricians and adult-focused physicians have actually advanced the field together. And I'm going to also delve into the fluid overload concept a little bit more than Dr. Bidney had, because a lot of what we saw, what he presented, was initially seen in children. If you want to understand pretty much the current state of the art of CRRT in children, not in infants, please refer to the prospective pediatric CRRT registry, which was a 13 U.S. from 2001 to 2005. 370 patients were entered. Patients were aged 1 day to 25 years, and we had unrestricted industry funding from these sponsors, and those were the days when you could get unrestricted industry funding. We had 13 papers that looked at every aspect of CRRT, from access, placement, to timing, based on fluid overload, anticoagulation strategies, various different patients, whether they were receiving CRRT for non-renal indications, patients with multi-organ failure, infants and children. So I refer you to that compendium. Which children get CRRT? Well, out of the PPCRT registry, Jordan Simmons' paper shows that it's pretty much what you are seeing on the adult world. So, diagnosis. What was really critical here is that sepsis, bone marrow transplant, heart disease, liver disease are really the most common primary diseases leading to the need for renal replacement therapy. In fact, primary renal disease accounts for only 8% of the disease burden for patients who are critically ill requiring CRRT. This really makes it imperative that nephrologists work together, because if nephrologists are only interested in primary kidney disease, then they're going to show up late to taking care of these patients. You can also see the percent survival. And while patients who had liver disease and bone marrow transplant had a lower percent survival, I'll point out that the survival was not zero. And you could still go to some states where people believe wheeling in the CRRT machine was wheeling in the Grim Reaper as well, and that every patient who got put on CRRT was going to die. What I would propose is that for any disease state, if you wait to try a therapy when it is too late to attempt it, then the survival will always be zero. So we have to think like critical care nephrologists when we're moving into this space. If we also look at children from the PPCRRT registry, we can see that the types of diseases are exactly the same: sepsis, cardiac disease, oncologic disease. So infants aren't just small children, and children aren't just small adults, but the diseases that lead and the need for CRRT and acute kidney injury are the same. So I do want to state that we should not forget PD, especially in challenged areas. And in fact, in the post-op cardiac surgery population, we have data to demonstrate that early initiation of peritoneal dialysis at sub-rifle, sub-Clinigo stages of acute kidney injury is associated with earlier extubation, earlier time to negative fluid balance, and in our institution, based on the underlying congenital heart disease, a PD catheter is placed at the time of corrective surgery, and when patients 1 ml per kilo per hour of urine output that is not responsive to Lasix for 4 hours, so a modified furosemide stress test, patients are started on PD. These patients don't have hyperkalemia, they don't have severe acidosis. We're managing their fluids and preventing electrolyte derangement. So this diagram is how I think about managing acute fluid in patients with acute kidney injury. And I'm not at all involved in the resuscitative phase. That phase is the domain of the intensivists that I work with. But where we are involved is to try to understand when is the resuscitative phase complete, when is fluid no longer going to be of benefit, and when should work in the maintenance and homeostasis phase, not to remove fluid, but to prevent worsening fluid overload. Intensivists, I think, when we started to deal with or propose this strategy, were concerned that they had done so much work to resuscitate the patient that what we wanted to do was to come in and make the patient fluid balance negative. In fact, I almost never make the patient fluid balance negative in the first 48 hours. I just want to assist, as Dr. Goldstein said, to provide the blood products, nutrition, medications needed without worsening fluid overload. And so our decision around the bedside is that if a patient without AKI cannot tolerate the needed fluid volumes, whatever the intensivist would like to give optimally, without developing or worsening fluid overload, we only have 3 options. We can fluid restrict, which means we can starve the patient. We can give diuretics, or we can consider renal replacement therapy to maintain homeostasis. And the reason that I think that the whole fluid overload and the associations that we found in our interest in this is that as pediatricians, we dose based on patient weight. We dose drugs in milligrams per kilo. We dose fluids in milliliters per kilo. We do not give a gram of this or a vial of that. And we also have a preventive mindset. We vaccinate. We talk about putting devices into the electric outlets so kids don't electrocute themselves. So these 2 things to me have our perception about fluid overload. In addition, a small patient, a baby who is 200 milliliters fluid positive, that can be a dramatic amount of fluid positivity for that patient, or it would be imperceptible to an adult. So we came up with a very simple method of measuring measuring fluid overload. So we looked at the fluid in liters to CRRT initiation, minus fluid out in liters from ICU admission to CRRT initiation over ICU admit weight. We did not care what happened in the ambulance, in the ER, in the elevator, in the stairwell, or in the hallway. We assumed the patient was being resuscitated. And by normalizing to patient weight, we came up with a percentage. We have looked at this in a study called AWARE, which the data will hopefully in the next few months, looking at over 5,300 children. But the data I want to show you from AWARE shows the issue with diuretics. So we see that in AWARE, about 40% of patients receive diuretics, but we see this progressive increase in fluid positivity despite the use of diuretics. So, as you heard earlier today, I certainly would give diuretics. And in fact, I think all patients deserve a trial of diuretics, but we have to be incredibly deliberate about what we think diuretic responsiveness is and what diuretic resistance is. And we shouldn't fool ourselves by increasing the dose or changing the type to a different loop diuretic or going to continuous infusion is going to do any better. If a patient to a diuretic, they are going to respond to a diuretic, and if they're not, they will not. And responsiveness should not just be an increase in urine output, but is it allowing you, as the intensivist, to provide the nutrition, medications, and blood products you need without incurring worse fluid overload? So if we go back to the fluid overload calculation in this small initial study that's 15 years old now, what we found was that children who survived were on average about 15% fluid overloaded at CRRT patients who died were on average 35% fluid overloaded. And you could say, well, Stu, these patients had to be sicker. And I say, no, Louis, they're not sicker when we looked at their PRISM 2 score. But let's look at these numbers. Let's say we have a 40-kilo patient. 40-kilo patient at 15% fluid overload, that's 6 liters fluid positive. That's a lot of fluid. Let's think about a 35% fluid overloaded patient. That patient has received 14 additional liters of fluid in the ICU. I don't know if there's surgeons in the audience. First space, that's not the second space, that's not the third space, that is outer space. Giving that much fluid is going into the lungs, into the liver, into every encapsulated organ and choking them off. At that point, fluid is not doing what you think it's going to be doing in improving blood pressure. There have been a number of other single-center and multi-center studies all showing that fluid overload is significantly higher in children who die at the time of C versus not. Now, these are associations. We don't have a randomized study to show that prevention of fluid overload will improve outcomes yet, but the data all go the same way. And in reference to Dr. Mehta's talk earlier today, initiation of renal replacement therapy is one of 2 modifiable aspects of AKI. We cannot change if the patient has MODS or sepsis, but we can change when we start renal replacement therapy and we can withdraw unnecessary nephrotoxins. And when we look at this number of 10 to 20% continues to show up, and that's also been demonstrated in the CRRT study and other adult studies. If we look at what I think may be the most important study in the PPCRT, we trichotomize this, and I think I made up that word. We look at the difference between less than 10%, 10 to 20%, and greater than 20% fluid overload in the CRRT registry. And we did find increasing mortality. We did find increasing mortality between the middle group and the lower group, but not between the more fluid overloaded group and the middle group. We found greater percentage or prevalence of sepsis in the middle group versus the lower group, but not in the upper group versus the middle group. And the PRISM 2 score, which is like your Apache 2 score. Again, patients in the middle group had greater severity of illness than those patients who were less fluid overloaded. The difference between the middle and more fluid overloaded group. To look at it graphically, patients in this group were much sicker than patients in this group, but by no measure were patients in this group sicker than this group. So even though this is just an association, I have to wonder, why did these patients get more fluid overloaded? Did they need it? And when we look at a multivariable logistic model, the odds ratio for death for a patient getting greater than 20% fluid overloaded was 8.5. Higher than if they had cancer or bone marrow transplant, higher than if they had multi-organ failure, higher than if they had sepsis. And as I've mentioned before, we can't control whether a patient has MODS, sepsis, or cancer. We can control when we start renal replacement therapy. So the ADKey group looked at this as well and developed this conceptual framework to help us determine to initiate renal replacement therapy and fluid removal, and I won't go into this in detail because this will be discussed in the fluid management talk tomorrow, but we have to reassess as we move forward. We plan a trajectory. The quality improvement initiative that exists at our institution is 1, state what the fluid goal is for the day, and 2, for a patient on CRRT, and state in the chart whether you attained it or not. Having the discussion on rounds, you can improve the outcome for your patients by having a planned target. So let's finish the talk by looking at infants. So this is pretty obvious. This baby can pee. This baby couldn't pee. And this is what we really need to avoid, especially in the smallest of our patients. And unfortunately, until recently, we did not have devices that were specifically designed to treat this patient. All we have are adapted from adult machinery. We know from KDIGO all of the risks of acute kidney injury and when we should start to think about renal replacement therapy and move to a concept of renal support therapy. But I will tell you, neonatologists are even further behind than our intensive care colleagues because we have not had machines that work well for their patients, and so they have been, until recently, late to consult us. So we should start dialysis, the risk and the benefit, and again, being in the cradle of CRRT, this is the first infant, Dr. Ronco's famous patient who started CABH many, many years ago, now over 30 years ago. And so we are able to do this as a result of the work in Vicenza. When we look from the PPCRT data, yes, who are less than 10 kilos have lower survival than patients who are greater than 10 kilos, but the difference between toddlers and infants, the survival is exactly the same. So we can tell our neonatologists that if we start early enough, that survival is not zero. And looking again at fluid overload, we see the exact same thing. Greater than 20% fluid overload is associated with death in these infants when they start CRRT. So we should always start 20%, and in my opinion, less than 15% fluid overload. You have to have a really good reason to not start. So it's amazing that we can do this, and even with the best practices, this approach exposes the smallest children to added risk because the machines that we have currently in most of the world are adapted for them. However, there is hope on the horizon for infants. So, Gambro, now Baxter, has an HF20 filter that is optimized for smaller kids and is now being studied in the United States, currently available in Europe and in other places in the world. And we did begin the study in the United States, looking to use this device in children 8 to 20 kilos, and hopefully we will have this device available. Of course, we have to talk about Carpe Diem, and I was privileged to be part of taking care of the initial patient and also working on this manuscript. And Carpe Diem is the machine that has been developed for small babies. It's dedicated, it's not adapted. There are 3 filter sets with very small extracorporeal volumes, so we don't have to blood prime the circuits. The scale error is 1 gram per hour. Incredibly small. And the importance here also is that these roller pumps are where all the technological innovation lies. They are not pulsatile. The machine can be run as slow as 4 milliliters per minute without clotting. So this first patient, which was published in The Lancet, you could see was 60% fluid overloaded. And starting CRRT with Carpe Diem allowed the patient to become euvolemic over about 7 days and back to the baseline weight at about 11 days. In addition, you can see what the net ultrafiltration was, nutrition was able to be given, medications were able to be given, and this patient, who likely would not have survived anywhere else in the world, was survived in Italy. In addition, the machine can be adapted to do plasmapheresis and single-pass albumin dialysis. It's a platform for many different filters. There's another machine from where Dr. Forney hails in the United Kingdom. And the Nidus is more of a hemodialysis machine with a push-pull syringe mechanism. And again, this is a very efficient machine and can be run at very low blood flows. They've treated 11 patients with both end-stage kidney disease, cardiac surgery, and also inborn errors of metabolism. And what this graph shows you is that the Nidus is significantly more efficient in clearing small solutes than PD, which would be the treatment of choice for most infants of that age. And finally, we can adapt the machine. The Aqueduct, which was developed for adult heart failure patients, has the advantage of being a very precise machine in terms of ultrafiltration. And even though it can only ultrafilter 500 mils per hour for an infant, that's actually plenty of clearance. And a former fellow of mine, David Ashkenazi, has demonstrated excellent creatinine clearance, blood urea nitrogen clearance, and sodium balance using a modified form of the Aqueduct. And we've used this for a number of patients as well. So in summary, although it's hard to define, neonatal AKI is very common and portends poor outcomes, but things are getting better. Provided renal support therapy carries added challenges in neonates, but things are bright on the horizon. Smaller filters, newer dedicated machines, or adapting current machines have the potential to improve outcomes in the smallest of our patients. And I would like to say in conclusion, we can support a critically ill child with AKI with a number of modalities. Pediatric AKI and neonatal AKI do not represent futile syndromes, even in resource-poor areas. The pediatric perspective of prevention, especially in terms of fluid overload, may lead to better outcomes, and we do have these new I think will be outstanding and improve the outcome for the smallest of our patients. Thank you very much.